Hi everyone and welcome to ABC's Anesthesia Junior Anaesthesia Vivas. And today we have Erica. Erica is an RGA trainee, which means that she's going to be a GP anaesthetist in the next few years, and she's going through that process. And what we're going to do today is I'm just going to ask her a Viva style exam online so that she can learn, but also anyone who's watching and listening to the podcast can also learn from this. Now, full disclosures, I'm an RGA examiner, and so I make sure that the stuff I'm putting there isn't stuff that's on that I've created as Vivas for the exam. But that said, it's a lot of just general principles that we're going over, and this is the content that I will be teaching everyone, regardless of if I was an examiner or not. So that's just the disclaimer and disclosure there. But yeah, let's get started. So Erica, tell us about your journey so far.
So I am very early on in my RGA training. So I'm about 2 and a bit months in now to my 12 months of anaesthetics training as my advanced skills. So still very much on the upward learning curve, but really enjoying it so far. And looking forward to hopefully learning from the Viva opportunity. So thank you.
No worries at all. Hey, so I'm going to just read out the Viva, but you've already got it in front of you. And we'll go for, say, 20, 25 minutes or something. And at the end, we'll just go through and discuss how to, the things you did well, the things we can improve on, all the usual stuff. So we have a 60-year-old male for a laparoscopic cholecystectomy. The past medical history includes ischemic heart disease, type 2 diabetes, hypertension, and neuropathic foot pain. The medications the patient is on is Metoprolol, Metformin, an ACE inhibitor, Statin, and Pregabalin. And so the question is, what do you want to know on pre-operative assessment? And you generally get 2 minutes to kind of jot down. And so we'll give you that time now.
Oh, this is my 2 minutes. Yeah.
Yeah, but feel free to jump in earlier if you'd like.
Yeah, I'm probably all right to go because I've already had a week to think about it.
Yeah, good. Excellent.
Oh, good.
Let's go for it. So what do you want to know on assessment?
So firstly, can I just clarify this is an elective lap choly, not emergency?
Yes, it is. Good.
Cool, no worries. So I guess in addition to the routine pre-operative or pre-anaesthetic assessment I do for any patient, including an anaesthetic history, I'd like to specifically focus on this gentleman's comorbidities, in particular the severity and stability of his ischemic heart disease, type 2 diabetes, and hypertension. And specifically, this has relevance to rural generalist anaesthesia. I need to decide if he's suitable for an elective procedure in my rural hospital. So in terms of, I'm going to start with the ischemic heart disease. I would want to know, in particular for ischemic heart disease, what kind of ischemic heart disease he's had, whether it's just been a bit of stable angina or unstable angina, at what point it was diagnosed, or whether he's potentially had an NSTEMI or STEMI in the past, and if he's required any intervention for that. So whether he's got stents or potentially needed bypass surgery for his ischemic heart disease. I can see that he's on an ACE inhibitor, statin, and metoprolol, but I'd want to be assessing for other sort of cardiac risk factors such as obesity or smoking, whether he's got, we already know he has diabetes, or whether he has any other risk factors contributing towards an ischemic heart disease, sort of future risks. I'd like to assess the stability of his disease by asking about his adherence to medications and follow-up, as well as assessing for any ongoing symptoms of ischemic heart disease, so in particular if he has any chest pain or chest pain with exertion or at rest, shortness of breath on exertion, that kind of thing. If he has had an NSTEMI or STEMI, I should have said, sorry, I'd want to find out when that was, and if that was recently within the last 6 to 12 months, that would be very relevant to my assessment and decision-making. And then moving on in terms of the severity of his disease, I'd be wanting to look at previous records from specialists or general practice if possible, including investigations such as ECGs, stress echoes, echocardiograms that have been done recently, particularly looking at his ejection fraction and any regional wall motion abnormalities, and also looking if he's had any angiograms done, if I can get a copy of those reports and see how severe the disease was at the time of the angiogram. And then lastly, looking for any complications of his ischemic heart disease. So on history, if he's got any signs or symptoms of suggestive of heart failure, so orthopnea or paroxysmal nocturnal dyspnea, again, shortness of breath on exertion, which relates to his meds and exercise tolerance. So that's very relevant to my anaesthetic assessment. I can move on and talk about assessment of type 2 diabetes and hypertension. Do you want me to continue?
Yeah, please do.
Yeah, so with the type 2 diabetes, again, thinking about cause, but most likely probably just a bit of age-related, maybe lifestyle things, and then assessing his compliance to medication, so his metformin, and whether a doctor's ever suggested that he needs additional oral hypoglycemics. And I guess in particular, in case he's left it off, checking if he's on a GLP-1 agonist as well, in case he didn't think about that as a medication. In terms of the stability, asking about his glycemic control, whether he checks his sugars, what his most recent HbA1c was. in terms of severity of his disease, probably links to complications. He's already got neuropathic foot pain, which I'm going to assume is diabetic in its etiology, but assessing for nephropathy. We know he's got ischemic heart disease, but whether he's ever had stroke or peripheral vascular disease complications as well. And then assessing those if they are present, particularly the degree of chronic kidney disease, if that's relevant, or peripheral vascular disease as well. And then similarly with the hypertension, same thing again, is it primary or secondary hypertension that he's got? And if it's secondary to another medical condition, what is that? And what's the impact of that on my anaesthetic plan? Assessing the stability with what his blood pressure is at the moment, but also if he checks it at home during the day, adherence to medication again, and then again thinking about end organ effects of his hypertension, so things like ischemic heart disease or peripheral vascular disease, renal impairment again. So kind of interrelated in terms of what I'm looking for with those conditions. And then once I've done that assessment, I would be assessing whether he's suitable for scenario build to have his anaesthetic, or whether he may need to be referred for further testing before he can go under anaesthetic.
Is there anything else you want to assess for, say, with the neuropathic foot pain?
I think I'd want to assess the sort of time course of the neuropathic foot pain. So if it's recent onset, or whether it's been long-standing, and how severe it is. And in particular, how well it is controlled with the Pregabalin. So has we found that's been effective for the neuropathic foot pain, or is he still having ongoing problem symptoms? And I guess in particular, if that's impacting on, say, his ability to sleep or his ability to mobilise and do his daily activities, that potentially will impact on my METS assessment if he can't walk because his feet are really sore, as opposed to it being sort of a cardiorespiratory issue.
Great. So you covered all the medical disease and the assessment of that. Let's say you've done that assessment. What would you want to know on an anaesthetic assessment now?
Yep. So with regard to the anaesthetic assessment, I'd want to know about any past anaesthetics he's had. So what kind of anaesthetics, when were they done? And particularly in relation to, do they precede the onset of the ischemic heart disease, or has he had anaesthetics since then and been okay? Any family history of anaesthetic complications, in particular asking about malignant hypoxemia or sleep apnea, both in himself and other family members, because that might impact my anaesthetic plan. And then also looking to do an airway assessment as well, to assess what kind of airway is going to be most appropriate. So, mouth opening, general approach to dentition, Mallampati score, thermomental distance, and how well he can extend his cervical neck as well, to assess whether I think this might be a difficult airway.
Good. Now, you've considered all the things on the history, and I haven't given you any information about that. What, from an ischemic heart disease point of view, what would make you want to postpone the lap chole?
Yep. So I would want to postpone the lap chole for this gentleman if his ischemic heart disease history was recent. So, for example, if he had a STEMI, say, in the last 6 to 12 months. I'm going to say, to be conservative, in the last 12 months for a STEMI, because he's probably likely to still be on dual antiplatelet therapy, although I notice that he's not on aspirin or clopidogrel at the moment. I would also consider postponing the surgery if he's having ongoing symptoms of ischemic heart disease. So if he's having angina-like symptoms with exercise or at rest, suggestive of unstable angina, I would want to postpone his procedure until after that's been thoroughly assessed.
You're good. Now, next, let's say ischemic heart is actually really well managed. He didn't have a stent, just had a very mild non-STEMI back 5 years ago. Everything's stable, good exercise tolerance. The diabetes is well controlled now. Let's say HbA1c is like 4.5. Blood sugar levels less than 6.
Wow.
Yeah, it's really great.
Good on him.
And the hypertension also well managed. For his neuropathic foot pain, this patient is on the Pregabalin and does have regular flare-ups and takes Panadine for pretty regularly for the flare-ups as well, and wouldn't say it's good control, and definitely has some disability from that. Let's go with just take that information in. What would you need? Given that information, what would be your anesthetic plan for this lap chole for this patient?
Yep. So I guess in terms of the anaesthetic plan, I'll take your structure of the 4M. So I'm going to think I'm going to need a machine or a bag mask, ventilator, bag mask.
Actually, let's go with that one.
Oh, no,
I've chucked an extra.
We're talking about medications.
I've chucked an extra question. Let's say you're making a broad.
You want me to talk about the medications?
a broad high-level plan of how you do this anesthetic, very briefly, but addressing some of the things you found on assessment.
Yep. So it's a lap collie. So it's going to be a general anaesthetic with muscle relaxant on board and an endotracheal tube as well, given that we're doing intraperitoneal surgery. So that's the high-level plan. Given that he's got fairly well-controlled ischemic heart disease and type 2 diabetes, I think he probably is suitable to go ahead in a rural setting, given that those are very stable comorbidities. I'm not sure if you were trying to get something else, but basically it's a GA.
That's absolutely right. What would you, would you do anything differently about the medication, the pain management plan for intraop? Pain management plan intraop, I would do as I would for anyone else. And if his renal function is able to, it allows, I would give him some paracoxib, some dexamethasone, consider some IV paracetamol intraop or giving it post-op as well. He would get some version of opioid during the anaesthetic as well. So if I use something really short acting for induction, giving him something a little bit longer acting, such as oxycodone during the operation to provide some post-operative analgesia. I think in this gentleman, if he was fairly stable intraop, or particularly if there was actually any degree of hypertension, I consider giving some magnesium as an adjunct analgesic as well. And if there was any concerns that he's potentially, or there is concern that he's potentially high risk for post-operative difficult to control pain, given his diabetic neuropathy, you could consider another adjunct such as IV lignocaine or IV ketamine during the intraop period, or even tramadol, and then making sure he's got adequate analgesia in the PACU and post-op setting. Yeah, great. Do you know how you would run lignocaine and ketamine?
I can probably answer better for ketamine, having seen it a bit more. So I would start with an IV bolus of, I think it's about 0.5 milligrams per kilo. So do I have a weight for him? Sorry, that might help actually.
Let's say he's 70 kilos.
So something along the lines of starting with maybe a 30 to 40 milligram IV bolus of ketamine, and then you can run an infusion of about 0.3 to 0.5 milligrams per kilo over the next hour. So again, it would be giving something like 30 to 40 milligrams over the next hour while he's in his lap collie. Hopefully the lap collie is fairly straightforward, and that should be sort of enough to get us through the whole operation. With the IV lignocaine, I'm less familiar. I've only seen it done a couple of times. Obviously, thinking about toxic dose is important. So calculating what I definitely can't give more than, and also considering whether the surgeons are going to be inserting any local anaesthetic into the port sites at the end and using that to make sure I'm well under the toxic dose for lignocaine, which without adrenaline is going to be 5 milligrams per kilo. And then similarly running that as an infusion IV relatively slowly.
Now, 5 milligrams per kilogram. What's the site of administration for the max dose of lignocaine when you're talking about?
That's probably for like subcut, isn't it? Yeah, not directly into the vein. So I wouldn't be going up that high. If it's IV, probably a much, much lower dose.
Good. We'll leave that for now. So I went off track from the questions I was going to ask you. Sorry about that. You did well. Let's say you're about to intubation. Okay. What do you need for intubation?
Okay, so now I get to utilize my 4M structure. So I need an anaesthetic machine or a bag mask, and I'm going to check that the machine's working, obviously, or have my assistant have done a machine check beforehand. I need monitoring. So I think for this gentleman, standard ANSCA monitoring for a general anaesthetic will be appropriate, plus neuromuscular monitoring because he's going to have paralysis, and VIS monitoring if I'm considering running TIVA, which I probably would. And then I will need my medications, which I might circle back to in a second. And then the Mabels, so that we need some masks for pre-oxygenation. We need some airway adjuncts, so oral pharyngeals or nasopharyngeals, as well as LMAs in the drawer. Stylets and bougies. We need a video or direct laryngoscope. And we need suction available as well. So they're the equipment. And then in terms of medication,
What was E?
What was E? Endotracheal tube. That's pretty important because I'm going to put that in after I introduced him. So making sure I have appropriately sized ETTs and then, a size either side as well. In terms of medications for the induction, so it's probably, given it's intraperitoneal surgery, he's going to be well fasted though, so it's elective. You could probably argue that you could do a modified RSI or even a standard induction, depending on the situation. I'm just trying to think about that because he's not obese either. I'd probably still go for an induction with propofol, rocuronium, and alfentanil, so a sort of modified RSI, potentially with a slightly lower dose of rocuronium if he's well fasted and not nauseous, because we don't introduce the full RSI dose. And then once he's induced, giving propofol as maintenance, and as I mentioned, some longer-acting opioids such as oxycodone throughout the procedure.
With MFA medication,
Yeah.
what are the other drugs that you want to make sure you have, even if you're not going to use them?
Yep. So I want to have my emergency drugs as well. So having some metaraminol drawn up, particularly for sort of post-induction hypotension, having adrenaline drawn up, or at least knowing exactly where it is and ready to go, and having atropine as well for bradycardia, which particularly is relevant given this is laparoscopic surgery. So with insufflation of the abdomen, we need to be prepared for the vagal response from that.
Okay, so you go ahead, you do, the intubation goes absolutely fine, and you're smooth sailing. Actually, let's give you a couple of problems. During insufflation, you suddenly hear the heart rate decrease. What do you do? Sure.
So the first thing I do with our surgeons is to stop insufflating in that moment, and if possible, start taking the gas out of the abdomen, because I'm making the assessment that it's most likely related to the vagal response to peritoneal stretch. I would then, hopefully I've already drawn up my atropine as discussed. I would give 600 micrograms of atropine IV as a push, and await for a response. And I would also be quickly,
Yeah, so you're about to look at what
scan the monitors.
Good. The heart rate is actually 20 as you're telling the surgeons to desufflate.
Okay, all right. So the heart rate is 20. So they're taking the gas out of the abdomen. I'd want to quickly look at the other parts of the monitor. I'll probably hit recycle on the blood pressure, and then immediately go to the patient and see if I can feel for a carotid pulse.
Low carotid pulse is present, obviously. Yeah.
Okay. I'm trying to remember, because there is a point at which you have to start CPR for severe bradycardia, and I can't remember if it's a bit like they've still got some output that's going to be severely impaired though. So you've taken the gas out. You can still give some atropine, but you'd have to be prepared to ask someone to start CPR if the heart rate doesn't rapidly improve and the output's insufficient to maintain the hemodynamic stability, essentially.
How much atropine are you going to give?
Start initially with 600 micrograms. Yeah, 600 micrograms initially, but then you can repeat that up to sort of 1,200 micrograms.
Anything else you do after giving that 600 straight away, as soon as you give that, is there something else you can do?
You want to flush it to make sure it actually gets in. So don't just leave it sitting in the line, to give it a good flush, and probably open the IV fluids to make sure they're running as rapidly as they can through your cannula as well.
Good.
As I said, I've already recycled the blood pressure.
After 1,200 mics of atropine and flush, the heart rate goes back up to 70 and everything's stable. They're going ahead with the operation. Your next problem occurs is you hear the saturations quite kind of trend down towards 88%, and you've got your normal setup. You're running FiO2 of say 40%, and all your ventilation parameters as whatever you choose them to be, pretty standard. What do you do at that point?
Can I just clarify, the surgeons now re-inflated the abdomen?
Yeah, so now let's say we're 30 minutes into the dissection.
Okay.
Everything's going smoothly.
Okay.
And saturations are down.
So we're about 30 minutes in and saturation's going down. So I think my immediate response to decrease in saturations would be to turn the FiOs up to 100%, and ensure that I have adequate gas flows. So if I'm running sort of low flows, increase that to say 4 to 6 litres a minute, and then do a rapid scan of the monitors, just assessing my other parameters like heart rate and blood pressure, and in particular looking for an end-tidal CO2 trace and taking note whether that's changed at all from what I had earlier in the case, as well as quickly scanning the ventilator and seeing what the airway pressures are doing. I then move from there to the patient and sort of assess how they're looking. So are they blue and clammy and grey? Do they look like they've lost output? And also looking to where the SATS probe is and making sure that it's still in an appropriate position, and assessing the peripheral circulation in that spot. So, making sure that I think this is an accurate SATS trace.
Great, just to give you...
and then if I think it isn't... Oh, sorry, go.
Yeah, I'll give you some information. So, you do all that thing. So, there's a good SATS trace, and your ventilation parameters haven't changed much at all that you notice. And everything else looks reasonable. The other observations haven't changed much, and the surgeons, there's nothing that you can really observe there that's giving any clues. But you've got a proper SATS trace.
And the stats are still 88%, or are they rapidly dropping at this stage?
No, so they're now stabilized. In fact, with your maneuver of 100% oxygen and increasing the flows, the saturations are now up to 92% on 100% FiO2.
Okay, great. So I've got a bit of time to sort of figure things out. One thing I didn't mention earlier is obviously checking my circuit sort of from wall to machine to patient and making sure there's not been a disconnection, because it could have just been a simple disconnection in the and loss of oxygen delivery to the patient could have caused this. But assuming that's all fine, I'd then go over and do a bit more of a thorough assessment of the patient, including feeling for any subcutaneous emphysema, and then auscultating the chest as well, listening for things like wheeze, or whether I can only hear air entry into one lung, in which case maybe my tubes become endobronchial in the course of the case, particularly the positioning of the patient, things like that.
What are some causes of hypoxemia, and how would you rule each of these causes out?
Yeah, I mean, there are many. I guess knowing that I'm 30 minutes into the case, I guess it depends what I've given, but generally if I was expecting anaphylaxis, I would have expected it, when I'm giving medications at the start of the case. So unless I've just given something that's brand new to the patient and then this has happened, then probably less likely. Thinking about like bronchospasm or reactive airway, so that's where the auscultation comes in handy. Similarly, endobronchial intubation, I guess that would probably be more likely if that's a low post-intubation, but I was confident that it wasn't esophageal. So we've got end-tidal CO2, but sort of inadequate sats. It can also be related to the position. So I think less likely for a lap poly, but as lap appendix, they have sort of head down and the pressures, sort of basal atelectasis can cause a decrease in saturations. You can have aspiration as well. But again, that's less likely if we've, secured the tube and there weren't any concerns of aspiration at the time of induction. What else? As I said, there can be equipment errors, so loss of oxygen flow, issues in the circuit.
Right. That's a good set of differentials. So when you auscultate the lungs, you hear quite coarse crackles throughout the lungs.
So that makes me worried that there might be a degree of pulmonary edema for this gentleman. It sounded like when we assessed him pre-op, there wasn't a lot of history suggestive of heart failure, but it could be that.
Let's say he was very well managed from a heart failure point of view.
Okay. So, but we've got coarse crackles, both lungs.
Yep.
I guess the other thing that could cause crackles would be something like aspiration if that had happened very surreptitiously on induction. Or
what would you do?
I think what else?
That's right.
Sorry.
Yeah. What would you do regardless? So it could be a few of these things. What would be your next intervention?
I could think about altering my ventilation parameters potentially, particularly if I thought it was like pulmonary edema, providing a little bit more PEEP or something like that to see if I could work with that, or breathe might if I was worried it was fluid.
Yeah.
If I'm worried about aspiration, that's a bit more difficult.
Is there anything else you could do to help things along with coarse crackles?
I'll ask for a chest X-ray if that's possible, intra-op, to help me with my differentials.
Yeah, that's right.
I don't know if that's possible. It's a bit difficult when the surgeon's in mid-op.
Let's say that the experienced nurse has a listen as well and goes, "Oh, that sounds like." Actually, when you're trying to puzzle through this, the admission nurse comes in and goes, "Oh, look, I forgot to tell you that this patient didn't want anyone to know, but he's been smoking 2-pack of cigarettes every day for the last 10 years." Does that change?
Oh, okay. I guess in that case, it could be some kind of COPD that I'm diagnosed with this patient, causing the crackles, in which case potentially could give a trial of a bronchodilator to see if that helps at all, though it's crackles, not wheeze, so that makes me less inclined to use a bronchodilator.
Is there anything else that is common in people that smoke, and actually probably common in lots of people anyway?
Mucus?
Yeah, what would you do if you thought it could be mucus?
Oh, sorry. You could do suctioning down the tube, so inline suctioning to see if you've got like a big mucus plug or something down there. Yep.
Now I'm going to give you another hypothetical. So what I did there was, whatever you didn't say, I made that the cause.
Okay. It's like, wow, I'm really sucking at these different.
No, you're not. It's to get you to be extremely thorough with your assessment, which you were.
Yep.
And then you went through all the differential, but you didn't mention that one, so I'm going to make it that one. Good.
Fair.
Well, actually, really unfair, but fair when it comes to down. So, let's say hypothetically, you could all your interventions didn't work, What would be your assessment? You mentioned chest X-ray. Is there anything else you do for assessment of hypoxemia?
I think an arterial blood gas would also be helpful. So if I've got an arm free, getting an ABD or maybe even placing an outline if I have the time. So taking an arterial blood gas to kind of assess the acid base balance, but also the PaO2 and PCO2 and seeing what's happening there. Chest X-ray, as I mentioned.
You do an ABG and the PaO2 comes back at 200. What do you make of that?
That makes me think, that means there's very good oxygen saturation in the blood, but we're getting a poor sats trace. So then that makes me wonder if there's an issue more with the peripheral perfusion or the accuracy of the trace or the reading that we're getting.
I've made a mistake there. Let's say your maneuvers somewhat help your saturations. The patient's on an FiO2 of 100. Your saturations are, say, 95%. And then you get this ABG back showing a PaO2 of 200. What do you make of that reading?
I guess it's related to the fact that I'm giving 100% oxygen. So I'm increasing the gradient for oxygen gas exchange in the lungs by doing so.
Is that
and it probably means that I'm over-oxygenating the patient a little bit.
Would you expect...
Is that normal? No, there's something weird going on with this patient. I can't put my finger exactly on what, but there's something not quite right. The physiology of that.
Great. Good. So there's an increased AA gradient. So you definitely have a problem with gas exchange there. Good. Let's remove that hypothetical and go back to the case. What do you want to prescribe? This case goes without event. You suction the sputum out. Saturation fine. Now this patient is on the ward and complains of increasing pain. How do you manage that post-op pain?
Yeah, so assuming I had given my intraop analgesia as discussed, can I know what's his renal function doing? Can I give NSAIDs or?
Yes, you can.
Okay, great. So post a lap chole, the most appropriate analgesia regime sort of at baseline would be multimodal analgesia, including regular Panadol, a regular anti-inflammatory such as celecoxib, sort of 100 to 200 milligrams daily or BD for 3 to 5 days post-operatively, and then utilizing opioid analgesia, so either rescue or breakthrough PRN. So for this gentleman with normal renal function, he's 60, so relatively young, something like a first-line oxycodone 5 to 10 milligrams every 2 hours as required for pain, and then second line would be tapentadol or tramadol 50 to 100 milligrams.
Right. You've done that, and you've noticed that the patient has been getting regular 10 milligrams 2-hourly oxycodone for the last, let's say, 8 hours, and has regular tapentadol and has been given all the other non-steroidals and paracetamol, and still has been having regular 7 to 10 out of 10 pain. What else can you do about that?
So I guess the important, and what day post-op are we? Are we immediately post-op?
Let's say day one post-op.
Day one, okay. So I firstly need to assess the patient and in particular assess his sedation score, given he's been receiving quite a lot of opioids, but I'm assuming he's complaining of pain, he's not overly sedated. And then I'd probably want to just do a brief examination, in particular focusing on his abdomen and thinking about, is there any potential surgical issue here that is contributing to quite marked pain post-operatively? And if need be, liaising with the surgical team regarding that. If there was no concerns that there was something untoward,
nothing untoward.
The surgeon's happy. Great. In that case, as discussed with his pre-existing neuropathic pain, he is slightly more high risk for post-operative pain, and he's really maxing out his opioid analgesia. So at this point, I'd consider another adjunct, such as if his blood pressure allows, such as clonidine, 50 micrograms IV, just as a stat dose to see what effect that has, particularly if he is just stressed with the pain. Another option would be something like, you could try converting him to a PCA, but I think given he's already using a lot of opioid and it's not helping it, I'm not sure how effective that would be. Another option would be trying just a small dose of IV ketamine, like sort of a ward-appropriate dose of, say, 10 to 20 milligrams, and just seeing if that has any effect. And then essentially watching for a response and reassessing from there. And particularly if I'm in my tertiary hospital, I'd probably be wanting to get the acute pain service involved, because this pain is sort of more than what we'd maybe expect for a post-lap chole.
This might be beyond scope, but any other anti-neuropathic agents you could think of to use?
Anti-neuropathic agents. So he's already, obviously, we're continuing his Pregabalin that he's already on. trying to think. I'm only thinking of other things we can give for just diabetic neuropathy at the moment. I'm not sure, sorry.
No, that's right. Hey, that comes to the end of the Viva. Well done.
Oh, really? The quick 20 minutes when you're stressed.
Yeah, no, that was like 10 minutes. Good. Yeah, so hey, you did really well. I'm definitely pushing you because you're doing well. Okay, so there's kind of
there are a lot of curveballs I wasn't prepared for, but that's good.
Honestly, you did so well with that. So the first thing you did really well was definitely from the ANSCA point of view. So the people who will be examining you are fellows, so the rural FACROMs and GP anesthetists. So they're part of the kind of RGA graduates or grandfathered in, and FANSCAs. And definitely the way FANSCAs will write Vivas will think about the severity and stability of disease, because when you get a diagnosis, what do you really care about? You care about severity. How bad is it? You care about how stable is it? You care about the cause, complications, and you did that really thoroughly, really well. So yeah, pretty much asking all the usual things with ischemic heart disease, diabetes. Hypertension is one of those ones that it'd be an unusual thing for hypertensive disease to ever cancel a case. Unless it's causing asymptomatic problems or it's in like the unheard of categories of like above 200s. But most things, you don't really cancel. In the scenario, you probably will want to check that and just go, above 180, this needs better control. But realistically, it doesn't. You can't get that control because for a number of reasons. Anyway, so you did that well. Don't forget to reassess the neuropathic foot pain, because then it's a whole thing of what's their control, are they having breakthrough, and the problem with this is that as soon as they're having multiple Panadine thoughts, suddenly I go from a well-controlled, I don't have to worry too much, to even though the surgery is in a completely different part of the body, they've got a level of sensitization that means they're at risk of pain. And if I was in a smaller hospital, if they had poorly controlled neuropathic foot pain, I'd be like, if we can't run ketamine, we don't have an acute pain service, I may reconsider doing this in a small hospital. The question of a preoperative assessment it can be quite a broad question. So generally I'd say, look, aside from if I thought that there was lots of medical things that I need to talk about, I'd probably say something like, look, I do my usual anesthetic assessment, which I can go through if you'd like, but I really care about from the medical history point of view, these are the things I care about. And that's where you went, which is totally fine. And then I just said, oh, look, what would you want to know for your anesthetic assessment? And you went through a nice, detailed summary, including previous anesthetics, pure NV, family history of any problems, fasting status, aspiration, risk assessment, meds, allergies. And then we've already talked about the medical conditions. And then for examination, I would say cardiorespiratory examination, auscultate the lungs and heart. I know a lot of people don't do that now, but I'm a big fan of it. And airway assessment. That wasn't part of the exam, so we moved on quickly. I didn't have to really tell you more things. My next kind of curveball was like, after we went through that, as soon as you get that high, everything is stable. Oh, that's right. I said, what would make you, so the hypothetical question, what would make you not want to go ahead with the surgery? And essentially you told me from the ischemic heart disease point of view, you pretty much said, if this was an active cardiac condition or had some other thing, like they're on stents and they had a stent with dual antiplatelets or on clopidogrel, now we got to postpone. So you were quite accurate with that. So stents, generally speaking, 12 months is a good number for drug-eluting stents. Less, I think 3 months for bare metal stents. That you can stretch it to 6 months if you're, and a lot of cardiologists would approve that, depending on certain other factors. So that was good. An active cardiac condition, yep, you said the right thing. So if it's symptomatic angina that's not stable, it's unstable angina, great, that's active. MI, so MI within the last 60 days, that's also not great. So that would constitute active cardiac condition. Good. So that was a hypothetical. If it's bad disease, we now postpone, refer, and reassess. Or if it's recent disease. Next thing, so what's your overall plan? So high-level plan. This is general anesthetic with endotracheal tube. The only interesting thing there is this neuropathic foot pain is a bit of a problem. So now I'm going to potentially run ketamine. So what's your pain management plan? Very reasonable. Your ketamine dosing was probably on a higher end, but not crazy. So I would totally do a 0.5 to 1 per kilo of ketamine, probably the 0.5 per kilo. So let's say 30 to 40, that's what I'd do at the start. And I'd probably run 0.2 milligrams per kilogram per hour. That's kind of high end on the ward is 0.25, maybe 0.3, but probably not. So in intraoperative, I would be very happy to run 0.2 milligrams per kilogram per hour, and then just half an hour before the case ends, I just stop it as a practical point, so I'm not confused about why they're slow to wake up. Lignocaine, so 3 per kilo for without adrenaline, 7 per kilo with adrenaline, but that's subcut dosing. So just to let people know, there's probably a number of different regimes for this, but 1.5 milligrams per kilogram as a loading dose, which is often, just the lignocaine we often put into the propofol that gets close to it. So some people might just give that and that's it. And then we run 1 milligram per kilogram per hour. So for this patient, it'll be 7 mils per hour of 1% lignocaine. But that's beyond scope as well. So it's not like you need to know that.
It's also hopefully something I could have looked up had I required lignocaine IV.
Yeah, exactly. Like I think exams should really not be too focused on minutiae like that. Common things, if you don't know your adrenaline dosing, that's crazy. But the stuff that you might not do regularly, that's totally fine to look it up. So different people will assess what do you need for intubation thing in many different ways. The reason I did the 4 M's is because I haven't mentioned a syringe, I haven't mentioned tape, but it's pretty much like if I go to eat, and in theater, you pretty much would have most things. But if I went to emergency or ICU or the ward, I've got the regular stuff like syringes and tapes, but I need to make sure that I've got these very specific things. And that's why the 4 M's is absolutely exhaustive, almost, I'd say an exhaustive list of everything I need to say. And so you did that really well. Great. Then, by the way, feel free to stop me at any time.
No, that's okay.
Good. So we're now insufflating. So the things you did really well, we're like, okay, well, not only do you this is advanced stuff actually, you told the surgeon to stop it insufflating, but you also wanted to make sure that there was deflation. And so just by taking the trocar out doesn't mean that the abdomen is going to deflate. Like they need to actually potentially take the whole device out and get that pressure out. So that was really, really good that you mentioned that, because I don't think a lot of people would know to mention that. So as a practice point to everyone, if you've got a pneumoperitoneum associated bradycardia, make sure that they're letting down the gas. So you said that well. Atropine dosing. So you did say, the first thing I would obviously say with that is, what is the heart rate? Because if it's bradycardia, if it is 40, I don't need to do anything right now. But if it was 20, I do. So maybe I'd say that first. Scan my monitors.
What is the heart rate?
It's 20. Great. Desufflate. I would never give 600 for a 20. I'd always give 1200 without question.
Okay.
So that's just on the far, you need to address this quickly. And again, most people don't realize this, but if you give the 1200 or 600 at a low heart rate, it's just sitting in the vein because the cardiac output would slow down so much. So fast flowing drip, flush that. If you do that, you probably don't need to do CPR. I like the fact you questioned that and said, I'm not sure what the times to do CPR. There would be very little harm. I think it's not the wrong thing to do. If the heart rate was 20, maybe 30, I don't think I'd be doing 20, 10, definitely asystole. To get that round, a CPR is not the craziest thing to do. It would, I don't think,
especially because it would probably be very short-lived, right? Like you'd probably give the atropine, open your drip, give a few compressions, and it's probably going to recover by the time that gets around. I've had low heart rates, maybe I wouldn't say 20, but I think it's hard to read as well, because the number you see on the screen isn't actually the heart rate, because it takes a while for that to register. So I've definitely given the atropine and just flushed it quickly, thinking that CPR is not going to help flush it round, but flushing. So if I use my energy to flush the thing into the heart, that's going to be more effective than wasting my time CPR. But I'm not going to weigh in on that. But if you want to do CPR, that's definitely a good thing to do. I guess the other thing as well, if I'm considering CPR, would be pressing the buzzer for help, which I didn't mention. But if it was we need CPR for this bradycardia, getting more hands as well, probably would have been a good thing to mention.
In fact, with any of these crises that you're going to get, absolutely just say, I'm calling for help.
Call for help. Yeah.
The other thing you mentioned which was really good, was recycle the blood pressure. I think people forget that with a non-invasive, if you've got some level of cardiovascular problem, whether it's heart rate, you need to cycle the blood pressure as a non-invasive blood pressure is a historical measurement. So that was really astute that you mentioned that. Good. So that's the neuroperitoneum part. Then, your management of the hypoxemia was great. So initially, yep, you mentioned things I want to hear, which you turn up the flows, and it's a good subtle point. So if you turn up the FiO2 and your flows are 1 liter per minute, your FiO2 isn't 100%. So if you turn up the flows, then you get proper oxygen into this patient if that's what you want to do. So that was good. You scan the monitors to just check your environment, which I think is a realistic thing that we all do. And the extra thing that I often do, I like that you said I'm checking the ventilator to see if anything's changed, because that can give you lots of clues to any respiratory problem. I often just go to the bag, so I've got a sense of the compliance. It's not the wrong thing that you did, but that often.
No, I think in my thoughts about that answer, I was meant to say I would switch them over to the bag with APL on about 30 and see how it feels, because that could exclude a lot of things immediately.
Fantastic.
I forgot to say that.
It was when you get the circuit disconnection or whatever that, it's just so obvious. And anaphylaxis, you're right, doesn't happen often 30 minutes into the surgery, except if it's chlorhex anaphylaxis. That's mean time for IV anaphylaxis is in the first 10, I think 85% of all anaphylaxis are in the first 10 minutes, but then chlorhex is often skin prep, so it takes a while to build up. Just as a point.
Okay, that's good to know.
You mentioned lots of the common things. Endobronchial intubation, so common, and bronchospasm, so common. I think you mentioned
aspiration, but I said that hopefully know that.
Yeah, but things can happen. Like if someone's head down and they've got a lot of gunk there, just because you've got a cuff in a tube at some level of pressure, it doesn't mean that it's not impossible that people could aspirate. And and then, so you took the right steps. I've done my safety stuff. I've scanned the monitor. I've temporized the situation by turning my flows up and my FiO2 up. I'm now trying to consider differential. So straight away, you check the monitor, check the circuit, which is these days rarely a problem, but you check that, and then you auscultate. I'd also just say, look at the tube, because if I look at the distance, is it still 23 centimeters? It helps me to decide if it's endobronchial or not. And then auscultate the lungs, great. And that gets you all your answers, really. There's very little else that can be not ruled out with that. So, and then, it was just, because you didn't say it, I'm looking for some kind of sputum or mucus plugging. And that is such a common cause of hypoxemia. And, it's just like you put the suction tubing down and you get all of that gunk up, and the stats just often increase rapidly. I like that you were talking about things like APO and what you do for that as well, because PEEP will absolutely help, even with sputum plugging, just to expand previously closed alveoli. And with the ABG, I made a bit of a mistake there, but let's say the SATs are improved, you take an ABG and your SATs are good and your PO2 is 200, but your FiO2 is 100, you'd expect your PaO2 with an FiO2 of 100 to be like 500. So you've got a substantial problem here if that's the case. And so just because you're happy with a PaO2 and a SATs, the fact that you need 100% oxygen means you have no room to move or little room to move, and there is absolutely pathology going on. So the next question is, what is that pathology? It's all the cause of AEi gradient, which is shunt, leaky mismatch, diffusion abnormality. And that becomes a whole thing. I then asked you what you do to rule these things out. And I think a lot of people, potentially because the consultants that are training them aren't role modeling this, but if hypoxemia is serious, absolutely, you've done all your things with your numbers. You get a chest X-ray, you take an ABG. If you can't solve it with those things and interventions, then the next step is to potentially go get some other help involved, maybe even a CT scan to figure out what this is. Could it be PE as well, or some of the rarer things? So that was good. And then I think we went to now day one post-op pain management. And good. So you said all the right things. I've got a standard. Like, it's just good that you can say things rapidly, like to take a long time to say Panadol, and non-steroidals, tapentadol or tramadol, and oxycodone at good, decent doses. I think that's a problem for this exam, that you just have to get through things quickly, which you're doing the whole way through. And then because we've got a problem with neuropathic pain, you mentioned clonidine, great. Ketamine, absolutely. I don't know if in scenario you can run ketamine, but have to check up on that. But
not sure. It probably is very hospital dependent, to be fair.
Yeah, you said something reasonable. I'd give 10 milligrams and see if that helped. And if it helps, great. Now we can start deciding whether to transfer it or not. And then ward ketamine, max 0.2 milligrams per kilogram per hour, which is fine. And then, there's probably beyond scope of what you guys are learning. But what could you do for neuropathic pain? You could increase the pregabalin dose. You could give amitriptyline is the other one that might be useful. I'm not a specialist, so maybe that wouldn't be useful in diabetic neuropathic pain, but absolutely can be. You said the right thing, which is I would refer, ask for help. Oh, and you said the right thing, which was I would definitely want to rule out a surgical cause for this, because that's absolutely what you need to do. So that was really good.
So they're not hemorrhaging or something. With the amitriptyline, actually, I asked one of our pain specialists last week, I said, is there any good evidence about a particular agent for diabetic neuropathy? And she mentioned the amitriptyline in particular can be quite useful. So that's a good thought.
It's funny because NNT is high and it's one of the cheapest drugs. So it's just, it's got probably a slightly worse side effect profile than pregabalin and gabapentin, but amitriptyline. Oh, yeah. So that's it. Hey, Eric, honestly, you did really well. Like this, like the way you're thinking through things, it's absolutely the level that I wish everyone was at. So if you're doing at this level now, you just keep plugging away. It's you're doing well. If you want to do more of these sessions as well, let's do it.
Yeah, I think it can't hurt.
Can't hurt, right? Great, guys. So I might sign off there. Thanks very much for watching and listening. Please share this with anyone who might be interested, and we'll see you again next time. See you guys. Now, what's new with ABCs of Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.